Hello, everyone. This is Shonda J, your BCBA, and today we present Michelle Mayhem, uh, who is a BCBA who specializes in forensic mental health and ABA. We are going live. Michelle, you there?
Hello, hello. Nice to see you.
Yes. And then I also have my clinical assistant, my clinical ABA assistant, Mackenzie Sheridan.
Hi, everyone.
Yeah, so just to give you some background on who I am and what I'm trying to put out there, I'm the founder and owner of T Mental Health Alliance. It's basically a forum where we're just creating a platform. I'm sorry, creating a platform where we're focusing on creating resources, materials, CEU events, specifically addressing the adult population. But what makes us different, we focus on dismantling the ableism culture. We show you what it looks like, we create literature, resources around it, and then also we focus on interdependence. Now, typically, when you work with adult services, they focus on independence, right? Let's make these goals and make this person independent. Not realizing that we really need to focus on more of that interdependence model. So, what that is interdependence is focusing on creating goals, strategies, and plans around making sure that the support system can equally support the individual strive towards their goals. Because a lot of us don't realize we use interdependence every day. Every time you go to the store, you get in contact with someone to help you get what you need. And then also, too, we focus on caregiver guidance. I said it, not training, guidance. Because the caregivers, whether it's formal or informal, they already know how to support the individual. They just need that extra guidance and support on knowing how to really help the person be successful to minimize a lot of those vulnerable distress behaviors. So, with that being said, we're going to go ahead into it. We're going to give a formal introduction to Miss Michelle. So, Miss Michelle Mayhem is a behavior analyst working in forensic mental health, where she supports adults with complex behavioral and mental health needs using compassionate, evidence based approaches. She is passionate about advancing the application of applied behavior analysis within adult services and bridging the gap between clinical practice and real world impact. Michelle also provides behavioral consultation to adults in residential settings and values collaboration, ongoing learning, and sharing knowledge to better support both the individual supported and clinicians. Outside of her work, Michelle is focused on her own health and wellness journey and values meaningful connection, growth, and lifelong learning. I connected with Michelle prior to this, and she doesn't realize it, but she's a unicorn in this field. I don't know if anybody's familiar with that analogy, but unicorns aren't real. We don't see them. We hear about them. We know they exist. Well, who knows? We've never seen them. And we have Michelle. She's the unicorn because you've heard of behavior analysts like her in the field. You see literature referencing to people like her, but we never seen them. And you know what? We have one right here, Michelle Mayhem, who specializes in adult services, but specifically forensic mental health. And if you don't know about this, I'm glad you're seated at the table so you can find out.
That was such a beautiful introduction. Wow, thank you.
So, with that being said, what first inspired you to working in forensic mental health, and how did your path lead you here?
Oh my goodness, my path to forensic mental health was a little bit all over the place. So, to set the stage, I initially growing up, I wanted to be a doctor. That's what I wanted to be. And I did my undergrad and I volunteered in hospital settings. And I thought, I'm not sure if that's exactly the path that I want to take. So I did my undergrad in psychology and fell in love with a little bit of everything. I loved developmental psychology. I loved forensic psychology. I loved cognitive psychology and neuroscience. It was just all so exciting to me. I did a clinical practicum in my third year that introduced me to the world of applied behavior analysis. I had to teach social skills to an adult with a brain injury. And from that point on, I never looked back, and APA kind of became my path from there. And through the many years of working in the field, I've worked in residential settings with adults, in hospital settings, in school settings. I worked with kids doing traditional kind of ABA, IBI in a clinic setting. And after that, I learned so many skills, but I really wanted to go back to working with adults. Working with adults, I think, is something that I have discovered that I'm really passionate about. It's kind of where I started. And I think I like the idea that although with kiddos, progress is seen really quickly, it's not always that quick when we work with adults, but it's very meaningful when we see it. I think we are really unraveling years of learning histories in the work that we do. And the forensic piece was just an additional piece of the cake that really sold it for me, because it kind of tied my love of and passion of mental health and working with adults. The forensic piece was just kind of how it landed. It was in a forensic psychiatry setting. I applied to see, I had all of this experience that I could kind of work upon. And thankfully, they hired me, and I've been working in the field of forensic mental health ever since. And it's been about 5 years now.
So, for those of us who are very unfamiliar with forensic mental health and ABA, can you just give a brief description on what that looks like?
Yeah, so that's a great question, because it can look different to people in different settings. So I will preface it by saying that I am based out of Ontario, Canada. So a lot of the legislation and kind of the terms used will be kind of reflect that. So forensic mental health or forensic psychiatry is the intersection of the law and mental health. Typically what happens, and I'll kind of use the terms interchangeably, but ultimately it'll be kind of the same. So patient and client. I'm used to saying patient because of hospital settings, but my brain is also wired to say client because of my residential experience. So a patient has committed some sort of criminal offense, and after assessments, they've been deemed either not criminally responsible due to a mental disorder. I believe in the United States, they use the term like legally insane. Um, or they've been deemed unfit to stand trial. So that means they're not able to understand the nature of the court proceedings. They're not able to identify the possible outcomes and not able to communicate with counsel. So that kind of comes together. An assessment is done. And what happens is if they are found not criminally responsible or unfit to stand trial, they may end up in a psychiatric hospital setting, such as mine. So in Ontario, there are 10 mandated hospital settings, which they can go to, usually based on location. So in my location, they're there for usually all of the locations, they're there for rehabilitation. So they're there to get help further with either their mental disorder, get medication. Often there's a safety risk to the public, so we have to do various interventions from an interdisciplinary team standpoint to help get the person to be deemed safe enough to be rehabilitated safely back into the community.
Oh, wow. And I've worked with forensic psychologists where similar to your role, the difference is they just practice as a psychologist, but I worked with them in collaboration when people were like sex offenders, things like that, and they would basically develop an assessment, and then I would just pick, and they will refer me, and then I would just collaborate with them in the treatment planning. But you are basically both of those things tied into one pretty much. So yeah.
We have forensic psychologists as well. We have a wonderful team of different professions I get to work alongside with. We have psychiatrists, psychologists, therapeutic recreation staff, social workers, occupational therapists, nurses, mental health support workers, substance use counselors, vocational counselors, and then, of course, the medical team that we have attached to help address any medical concerns.
Yes. And I do have, if everybody sees me, I might look to my left. When I do these interviews, I actually develop a list of questions to guide the conversation. But I'm going to mention something that ties into this, but it's not going to be these particular questions that I have listed. I recently attended the Constructional Approach conference, and one of the speakers talked on interdisciplinary approach when it comes to just working with the care team and behavioral services. And you work with a lot of different providers. It's not just you're assigned to a case, okay, give us the BSP and we'll go from there. Like you are constantly collaborating with others. And I think people fail to realize when you work with adults, I don't know how it is with the children. I'm a little rusty. It's been a while still with kids. But when it works with adults, you have to have soft skills, you have to have professional etiquette, and you have to know how to master working with the interdisciplinary team. And I want you to kind of give some pointers on how you develop that skill and what feedback you have for anybody. Because sadly, when you're in school, yes, right now we are evolving where we're focusing more on ethics. We're evolving to focus on the more up recent ethics task list, and we're even going to the spectrum of focusing on OBM. But that's one skill that is not in school, how to work with adults and how to work with an interdisciplinary team and have those skills. So in regards to just what advice you have for somebody and just share some of your personal experiences, that will really help our listeners when it comes to that aspect.
That's such an important point. Yeah, you brought up an, a point that I was hoping to slide in here somehow is that these are a lot of things that I encounter that were not directly taught in school, in our supervision. I mean, sometimes these things can be incorporated depending on how you're how it goes, but they don't really teach you how to play nice in the sandbox. They just tell you that you should. So that's definitely been something I've had to kind of pick up along the way. But thinking of things in terms of pairing has been really, really helpful. How can we best pair with the providers that we're collaborating with? For many of the providers that I work with, we work at the same location. So some of those things can be easier to do. So it's helping with different tasks. I did a leadership course recently that talked about something called the 5 minute favor. I'm not sure if you've heard of that before, but it's essentially if there's something that you can do to help someone else, even for less than 5 minutes of your time, it can pay off in the long run. And I really like that idea in terms of thinking about how can we help other people. So that I think this is also very important when we're thinking about like the nursing staff in my setting are the frontline people essentially who are delivering things on a day-to-day basis. So if there's things that I can do to help make their lives a little bit easier with some of the ideas that I'm coming up with, ultimately that's at the forefront. And making sure that listening to what they have to say and really actively listening, not just saying, okay, we'll see what we can do about that, is so important. Validation and empathizing are two things that I think are very important to the work that we do with our patients, but also very important for the work that we do with our team members. Their concerns are valid, and you're not always the smartest person in the room. I think it's important to listen to different perspectives, see where we have common grounds, and then see where you can work together on things because there is strength in numbers. There's a lot of things that I do together very closely with occupational therapy, for example, especially in terms of things like coping skills, social skills, and adherence to activities of daily living. Um, and it's just easy to kind of add in, hey, we can do these things together. There's overlap in our scope, but these are your strengths, these are my strengths, and we can highlight it better together. In terms of the soft skills in a meeting, when leading a meeting, having an agenda can be really helpful to make sure that we're hearing everybody, but also making sure that we're staying on task. When we have a lot of very like people who want the best for the patient, but there's also a lot of different opinions coming in, we need to stay focused. So that's something that I like to have incorporated so that we have time to listen to address different concerns around the table, but also kind of remain on task. Things like, okay, what is working, what is happening currently, what is working, what's not working, how do we feel we can best approach this, and then also bringing your ideas to the table, having ideas ready to bring forward, so that you can provide that expertise, but also it doesn't have to be right directly at the forefront. Having that open forum is really, really important. And as well as finding those opportunities about where your value can kind of help highlight things. So, for example, in my setting, I might do things. Behavior analysts are very data driven. So it might be looking like things like, can we help with identifying patterns before patterns get worse so that we can help intervene sooner? This might look like showing our value by tracking behavior changes in relation to medication changes, and then seeing that, oh, we see a spike about 3 weeks if a patient is receiving an injectable medication, but their schedule is every month, so every 4 weeks. So perhaps we need to adjust to every 3 weeks so that we don't see that escalation after 3 weeks. And then we kind of show our value, but also we're not stealing anyone's thunder at the same time.
And I'm so glad you brought up a lot of good points. Um, a lot of good points. I guess I wanted to ask, do you have an example of when you had to, like, do you have any, of course, we got to make sure you don't mention any individual supporting names, but do you have any real life examples where you had to apply some of the recommendations you brought up?
Oh goodness, I feel like this is my life on a day-to-day basis. So for my particular service at the place that I work, I'm a referral-based service because I work across all of the different forensic units. So I'm not attached to every patient. So there is usually, if they're like, oh, we need to pull in Michelle to help consult on this, a referral is put in place. And then initially, after the referral has been reviewed, I like to meet with the team to get a sense of like the presenting problems, um, run through exactly kind of what I said, like what are the presenting issues, what's working, what's not working, and then whether or not I can provide some ideas right off the bat, or say that I need to kind of do a little bit of an assessment to see really what's going on and take a look at the data. In making, if a behavior support plan is required, in making the plan, I'll have the, like, I guess I'll draft something and then present it to the team and say, this is kind of my rationale for including these points. And touching base with before it even goes live with the entire team to make sure that I touch base with people to say, does this practically work for you? Because I could write the most picture perfect plan, but if the people who are implementing the plan are saying this is not going to work for these reasons because this coincides with like meal times, or like we're really busy from 9 to 10 because of breakfast and medication administration, I'm going to listen to them and think and take that into consideration and not just be like, oh well, like it's only going to work if we do it my way. That doesn't work. um, and so I really take those opinions into account. There are times where things need to shift, or like different reinforcement ideas come up. Um, and it's either a battle of saying, let's try it your way and I'll take data and we can track, or I'll push towards my way and be like, I think we need to try it this way, just because it might be something like, I think the reinforcement schedule needs to be a little bit more dense at the beginning, or I think we need to target these things and maybe leave some of the more punitive measures out until we see if this works first. Um, but having that open communication with the team to be like, okay, is this going to work? And then we go live and we, um, do all of. I love the term that you use, caregiver guidance rather than caregiver training, because you're absolutely right. The other people, they know the patient or the client. They work with them. They see things that you don't. In fact, many of them are often, especially in the frontline people who are doing things in residential and hospital settings, they see things that you don't. And so really helping just guide them towards the change that we want to see is really ultimately the goal. So I think something that's really helpful is, again, providing the rationale for things, because especially in my setting, it's very punitive heavy. We're very connected to things like corrections and jail mentality, and structurally we're secure. So there are things that we need to try to open our eyes to being like, have we tried praising these things? Have we tried these things? And hopefully I'm not veering off too much topic off the question that you're saying, but my mind's going all over the place too. Yeah, that definitely it can be a little bit punitive, and trying to reshift to the overall team to be like, maybe we should try this first is always helpful.
And I'm actually looking at my notes because I think we have a question related to that. Okay, so what you just said is very common in adult services. So something about me for my viewers, I worked in New Jersey with adults, I worked in Delaware with adults, and now I'm working in the state of Missouri. And even though I'm working in 3 different states, I noticed that same mentality, that punitive mentality you brought up, meaning as a care team, they need to do this. It's more of a compliance driven model. They need to take the they need, and then they call you in as a subject matter expert. Well, how can we get them to do this? Because we already took away this, and we took away that, we took. And it's just like, and that's where the whole ableism perspective comes in, because ableism is basically that construct of focusing more on that compliance-based model, where it's like, you need to fit the box of what we want you to do, and we're going to use whatever it takes to do it. But people fail to realize that as behavior analysts, we always focus on the least restrictive approach, and we always focus on reinforcement. We don't lead with the most restrictive, and we don't lead with the most restrictive. And it's because when you lead with the most restrictive, A, it's unethical as a BCBA. Like, if somebody finds out you're doing it, you're going to lose your license to practice. But B, just from a human standpoint, nobody wants to be in an environment where they lead with that punitive culture. Imagine you go to work and on day one, they're like, if you don't do this right, you're going to get fired tomorrow. You might, whoa, like, do I really want to work here? Or let's say you're dating somebody and they're like, you do this, I'm gonna break up with you tomorrow. It's like, whoa, like, I can't make mistakes and be human, So it's just one of those things where I'm glad you brought that up, because I know when it comes to interdisciplinary approach, me personally, I don't like to say buy-in. I like to say collaboration and flexibility. When I hear buy-in, it sounds like I'm trying to manipulate you to think what I think and walk away with that narrative. And when you use that approach, you're really focused on, this is my plan, these are my ideas, and I want y'all to do it. And I'm going to use whatever I can to buy in to get you to walk away with it. Not realizing that that can kind of be aversive, because everybody feels like you said with the sandbox, like, wow, like, we can't play with her because every time we walk in, she's trying to get us to walk away with her narrative. So with that being said, I say all of this to say, I guess, kind of piggybacking off of you, when it comes to that collaboration and also flexibility. So if somebody says no, be okay with it. Now, if they're saying something that's no, that is something that is at harm to the individual and themselves, okay, now we gotta be adamant to advocate for the person. But if they're saying, like, I don't like your idea, it's okay. Like, okay, well, let's see what does work. But I'm so glad now. I feel like I'm going on a tangent, but I definitely agree with you with the punitive measures. So I guess my question to you is, when you walk in the room and you've noticed the care team has led with punitive measures, and they come in thinking that you are going to be the seance to reinforce these punitive measures, like what advice do you have and how do you handle those situations?
It's really tricky. So something that I do often bring up ethically, I have to suggest reinforcement-based measures first. If safety is always at the forefront, safety, particularly in the forensic context, my duty is to protect the safety of the public. So if there is imminent risk of harm to the individual themselves or to others, then there are times that we do have to act in a way that helps mitigate that risk. But I always try to encourage that if those things are being used for risk management purposes, for example, the use of seclusion or physical restraints or chemical restraints, that if they are used at all, then they're used for short durations. And you're going over with the patient, particularly like what has led them to be there, what are the target behaviors that we want to see in order for them to be able to come out, and what safety measures are in place that we can have them transition back onto the regular unit milieu as quickly and as safely as possible. Because it doesn't sit well with me when people have to be undergoing more punitive measures, especially the more severe ones, for longer. I also like to try to reframe the question of what are we going to do to stop this behavior from happening, and more so, what need is this behavior serving, and how do we help them meet that need in a safer way? So this helps promote the dignity of the person that we're working with. It kind of shifts them away from being like, bad or non-compliant, and the focus really becomes on what are we looking for, not what are we looking for them to stop, if that makes sense. So really trying to shift away from, okay, yes, this is happening, and there are natural consequences and contingencies that happen in a forensic setting, such as privileges to get off the unit are either granted or not allowed. Again, the safety of the public, including the people who are outside of the unit, is at the forefront. But are there ways that we can make this more safe? Is it someone who's going to be there to provide immediate feedback so that if something does happen, we can mitigate that risk as quickly as possible? What are we doing pro-socially to teach skills and replacement behaviors and help them meet needs? So I had, in many of our units, we are covered by glass around the care desk. And I worked with someone who would just pound at the glass just to get someone to come talk to them. And we did two things for that case. We were able to both shape the knocking, I shouldn't say knocking, a banging to a gentle knock, to eventually using words to get attention appropriately, while also having kind of like a schedule of basically scheduled attention to work as a preventative strategy, so it would reduce the need for having to bang at the care desk. So we both taught an appropriate response and then also prevented it by helping them meet that need appropriately. So bringing up also past examples, I find in having conversations where people want to try really punitive measures, being like, we can do something differently because we've done it before. And I think we can do it safely if we use, again, bringing back the team members' strengths. So we can have leisure-based interests at the forefront for this person. Like, how can we incorporate this in a safe way? How can we manage risk while also promoting interdependence? Is there a schedule that we need to come build in some prompt strategies? Because like you said, we all used interdependence. Sometimes I don't think I would be able to get up if my backup alarm wasn't going to work, if my husband wasn't nudging me to say, hey, it's time to go to work. Not that that happens because I'm the early bird in the relationship. But but yeah, how can we all work together and kind of building up on those strengths? And then once we put all of our heads together, we shift away from, okay, we can manage risk, but also rather than just this needs to be tackled, but it's the but also what are we going to teach? How do we meet their needs? When they're showing us these alternative behaviors, how are we capturing that in the moment and reinforcing that? How do we see more of the good things and focus away from the bad things? It's very tricky, but those are kind of the things that we like to lean towards.
Yes. And for those of you who are new to adult services or you're already in it, some examples of punitive measures are rights restrictions where the team tries to deny the person their rights. It could be something as simple as taking away their cell phone. It could be something as simple as um, any choice that they can make in a day to day. And I love what you brought up. I actually had a personal example where there was a young man, he was urinating everywhere, a young man. And one of the function of his behavior was to gain access, specifically in regards to his sexuality. He wanted to date. Da, 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 da. Was opposed to the idea. So before I came on board, she was taking things away. So when he would display certain behaviors, she took his phone. He displayed other behaviors, she took the TV. And she just kept taking to the point where his behaviors got so intense. That's when I got called on board. So the team was like, well, they got me on board. Like, well, what else can we take away to get him to do what he's supposed to do? It's like, we got the behavior analyst here now. And it's like, whoa, it's like what you said. Well, instead of us focusing on stopping his behavior, let's focus on how we can support the function. He wants to date. So let's see if we
Yes.
can find a specialist in sexuality who can help him learn discernment on how to navigate appropriate and inappropriate relationships. Let's even have the conversation with mom so she can kind of know how to support her son in all of this. Like, let's have these conversations to meet him where he is. And then let's educate the support staff so they know how to support him when he is dating or whatever. But you taking, it's like it. I don't think that the team realizes it. You guys hear me now? Okay, sorry about that, you guys. Had some tech issues. But also, too, you have to keep in mind when these rights restrictions do get put into place, because typically in adult services, anytime there's a rights restriction, the team has to go through Human Rights Committee. That's normally within your state or your county, whatever. Then they approve it. So once it's approved, sadly, there's this culture where once that person gets a rights restriction, it sticks. Like nobody revisits, tries to take it away. You got this right restriction and it follows them everywhere. So, as behavior analysts, it is your responsibility and due diligence to constantly analyze the data. And you notice that if that person's behavior is improving, you advocate for the measures, like Michelle said, what is the fading strategy so this person no longer has this rights restriction? Because that is definitely creating a culture of ableism, placing this rights restriction on them and then making no efforts to try to reduce it or fade it in any capacity. So I'm glad you brought that up. What Another question I have are, what are some common misconceptions about applying ABA in adult or forensic services, and how do you address them?
Oh goodness. In forensic services, I think actually it works for adults, it works for forensics, but one of the things that comes to mind is that one size fits all. I think something that we see, and I constantly have to help, with the help of my team, educate others about is just because something works really well for one person doesn't mean it's going to work for everyone. And it doesn't mean necessarily that we can apply the same strategies, yeah, across the board. Even some different units operate slightly differently. different clients within a residential house may have different interests, different ideas. Their behaviors don't serve the same functions. And so that's something that I feel like commonly comes up is why can't, okay, well, we did this thing and it worked really well for them, but why can't we do this? So that's something that constantly comes up, I think, for sure. In terms of other misconceptions, is that something that comes up is that we still should not use things like visuals because it's infantilizing, but not all visuals are infantilizing. So there are things that have come up where we shouldn't use something like a visual schedule because um, that's something that only works with kids. I'm like, well, do you use your calendar on Outlook? That's a visual schedule. It just looks differently. I don't know if you've ever encountered this with people, but this is something that surprisingly comes up, is saying that we shouldn't use certain strategies. And I also, on the flip side, advocate for they're also adults. We don't need to use infantilizing strategies, like things that we would maybe use with kids maybe not aren't going to work the same way with adults. Like if they can't understand text cues or visual cues, we can bank on that. I look up instructions to make recipes all the time. Just because I follow a recipe doesn't mean that it's a prompt that I shouldn't use. Um, so those are just a couple of the things that I can think of in terms of the types of strategies used. It kind of goes both ways. In forensic services in particular, I feel like there's a stigma that all of the people that I work with are extremely dangerous, and they're not. The range of things that have led them to be in the situation that they are ranges from a variety of different things, from like something small to some of the bigger things. So working with people who have either some sort of diagnosis, um, or have a certain mental health condition, or have these labels. Even the forensic label in general can be very stigmatizing. Community partners may not understand necessarily what that means and what it means in terms of the rehabilitative lens, because we're really there to help them get back. People change, people have the ability to change, and that's ultimately what we're doing, is helping facilitate change. So that's something for sure that I think is a misconception, that everything is so dangerous and scary, but it's at the end of the day, people are in the situations that they're in. Many have tried to get help and failed and have only been able to receive help because of the conditions that have led them there. And then also on the flip side is real. I don't think there's a single person that I've worked with that hasn't had some sort of trauma in their life. So really highlighting trauma assumed or trauma informed care in the work that we do, both as behavior analysts and also just healthcare practitioners working with adult services. Like I think I said earlier, we're working with years of learning histories, where it's not just a quick thing where, as kids, there's things that we can change rapidly because of how our brains work. But over the time, when mixed with substances, different mental health conditions and trauma, they all intertwine, and we're helping to rewire safer ways to get their needs met, safer ways to communicate, safer ways to promote autonomy. And yeah, ultimately, I hope that helps answer your question.
No, I love how you brought up learning history. As a behavior analyst, anytime I get a case, I always consider the ecological factors and trauma. Ecological factors, how were they raised? Because that's learning history. So if I grew up in a household where I witnessed my dad beat up women, like let's say I'm a male and I witnessed my dad for years beat up women, and now I'm an adult. The I'm in crisis, cycling in and out of crisis. Now this behavior expert is sitting in front of me, and one of my main vulnerable distress behaviors is beating up on women, normally most behavior analysts are like, well, how can we stop him from beating up women? But when you consider the ecological factors and you find out that he was raised in a household where he witnessed his dad beat up his mom and the mom never left, she stayed, that is a contributing factor to his learning history, because he has learned, well, this is what you do in a relationship. Like, I'm not doing anything wrong. Like, this is what I've seen all my life. I'm not doing anything wrong. I don't even know why I'm looking at you right now. So that kind of ties into that cultural aspect within the learning history, because you can sit there and come up with all these interventions, but from a cultural standpoint, if that's socially acceptable and that's a part of their learning history, you have to even dig even deeper. Because I know I had one case in particular where the young man would basically be sexually aggressive with his support staff. Like, he would grind up on them, he would say things about their body parts, and all the women felt uncomfortable. So we're making all these environmental manipulations. And then I end up talking to dad. And dad is like, I don't know why he needs behavioral services, because he's just being a man. And so that right there is telling you this is the learning history he has been taught. So it's like, now here goes the ethical boundary of, well, how do I navigate this? Because this is a cultural influence. So, and if you're in a case like this, I do want to encourage, make sure you seek counsel from a professional so you can navigate it appropriately. I am not by any means giving clinical recommendations. This is more so of a discussion from a subject matter expert, including myself and specifically Michelle, on just how to handle the day-to-day when it comes to adult services within our roles. So with that being said, you've spoken about bridging the gap between clinical practice and real-world impact. What does that look like in day-to-day work?
Yeah, so it's definitely a challenge to help, one, get everyone on the same page to look at sometimes both the big picture and then also the intermediate steps that we need to take in order to get there. So real world impact to me looks like hopefully helping someone achieve ways to, I think really goes back to that safety piece, is how can we get people to act safer, both to themselves and others. So I'm going to give an example. Without giving too much any identifying information, I worked with someone where they had a very traumatic background. The very punitive measures were used like before my involvement. And over the years of working with this person, they've been able to not only not use physical aggression to get their needs met, but are now able to use things. Like today, for example, they were able to use coping skills in the moment during a very difficult conversation.
Oh, wow.
I saw the deep breathing. I saw trying to ask for a space or in a break and those types of things. And to me, that is real world impact. We have helped someone not only develop the confidence that they don't need that same thing to help serve that need anymore, but found other ways for those needs to be met in a way that they feel safe and supported. And whether or not that person is able to then move on to somewhere in the community, like community placement, which I believe will happen, or even just within the context of the forensic unit itself. I think the real world impact to me, that's more on like the patient client perspective. I think that has been really, that's ultimately the goal. If we can see those changes happen, I think that's going to lead to better success in the future. And then I also think clinical practice and real world impact in terms of how confident and competent the staff who work with feel about dealing with those situations. So there would be times where perhaps even 5 years ago, staff who were in that room would have felt so unsafe to de-escalate a person that perhaps a code white, or a code white is what we use in the hospital setting for a violent situation, a code white would be called, or perhaps they'd call for urgent support because they're, and then fill the hallways with over 20 people, which in and itself can be really intimidating to someone who's in distress. But how can we help support people feel like they're able to de-escalate someone in a safe way that makes them feel safe and the other person feel safe? And that's really tricky because we don't always know what we're dealing with. And sometimes those old learned behaviors may reemerge because that is what helped serve them in the past. But I think the real world impact too is helping teach some of those fundamental preventative skills too, and communication skills, and helping people, the staff, see things also from a little bit of a reinforcement lens and how they implement that just naturally without having to be guided. I think that's also real world impact because that transcends not just the work they do on a clinical level or even at a residential level in that setting, but also how you just treat people as human beings outside of work,
Yeah.
I think is ultimately a really beautiful thing.
Yes. That is some great advice. Great advice. With that being said, Mackenzie, do you have any input or do you want to join the conversation in any way?
Yeah, I just want to say thank you so much for having me on this call. Everything you've shared is super important and valuable. I do have a question. I'm graduating college in 2 weeks, so kind of just trying to figure out my career path. And I wanted to ask you what advice you would give someone early on in their professional career and interested in ABA and making any meaningful impact with adults.
Oh,
Kind of
I
what
love
advice
this
you give.
question. I love this question. Something that I think is really important, and I think that I've tried to do because this was not something that I had either seeked out or even thought would be a possibility, despite having somewhat of a bubbly personality, is don't be afraid to reach out to people who are working in areas that you may be either less familiar with or you're interested in. Um, I think mentorship for me was really important in my current role to help make sure that I was on the right page. But something that I like to do too is chat with students who are interested in saying, like, I didn't know I saw a forensic behavior analyst on LinkedIn and I didn't know that existed. And
Mhm.
so those people who are stepping out of their comfort zones to ask questions, I encourage other students to kind of do the same and asking, how did you end up where you are now? I didn't know I wanted to be in this area until I fell into it and worked my way over to it. So asking those questions, making connections, I think is really important. And then also, um, yeah, not being afraid to step a little bit out of your comfort zone a little bit. I don't think I would have landed in ABA if I hadn't applied on a whim to the clinical practicum because I didn't think that was something that would be uh, I didn't know anything about ABA. I just kind of applied to see what would happen, and then I got accepted, and then I mean here I am. So I think taking opportunities and different learning opportunities too is really interesting to kind of see what you like, what you don't like, and then also it's okay if you change your mind. It's okay to like one thing and then say I want to try something new. I love the field I'm in. I'm probably going to stay where I am for as long as possible, if possible. But I also have a deep love as I'm learning and my skills are developing into a bit of the OBM space because the idea of creating change across a system level was really exciting to me. So it's also okay to change your mind, and I think that's something that isn't said enough, and it's also okay not to know. So that's something I would say.
Well, thank you so much for your insight. That was super helpful, and I really appreciate it. And that's how I've felt with Shanda with my mentorship. I feel like I've learned so much and gained so much insight and experience, and talking with you expanded that even more. So I really appreciate your advice and feedback.
Amazing. Thanks, Mackenzie.
course.
All right. So with that being said, anytime I do a discussion, a CEU, or any speaking engagement, I always like to end it with the seed has been planted. Now, how are you going to use it? So this just came from the one and only Shonda J, your BCBA, featuring Michelle Mayhem in forensic mental health, and then also starring Mackenzie Sheridan. And by the way, I know this is super random, but this is Mackenzie's last day with me. So yes.
Oh,
Yeah, I know this is
Sad.
gonna be out to the world. Everybody can hear, but no, Mackenzie is phenomenal. But with that being said, thank you so much, Michelle, for your time. Do you have any social media handles or any projects you want to promote while you're in this call?
I'm happy if there are listeners and or viewers that would like to connect because again, yeah, I'm kind of there's not very many of us who exist working in this particularly niche area. So if you want to connect on LinkedIn, just search up my name and I'd love to connect and chat.
All right. And I also put her LinkedIn information in the description. I know the description is pretty long, but if you scroll down, you should see the link and hashtag so you can just easily access her page. So, all right. Thank you, everyone, for joining us. And until next time, see you guys later.